this is the 2006 Society for Pediatric Anesthesia membership survey, and Christy Nelson, one of my colleagues, did this study, and it was 400 pediatric institutions in the United States and Canada. 70% of these were academic. We had 228 responded. Parental or nursing-controlled PCA is used by about half, and 33%, so a third of the responders used continuous infusions with IV PCA. So you can see this is not universally used. 77%, that's another controversial area in pediatrics and more so in adults, will use concomitant anxiolysis. So that's a child who is receiving an opioid, IV PCA, and at the same time may receive some Valium for, say, muscle spasm, or because they are worried about getting a dressing change. I wrote a particular protocol at Hopkins looking at this issue. So we have a policy for this management in children, and the adult interested in it. Monitoring for IV PCA. How do you monitor this? And when you look throughout the literature, you will see a variety of monitoring for respiratory function. One is pulse oximeter. You can monitor end-tidal CO2, so your exhaled gases. You could do EKG or respiratrace. And you see that most institutions, this is the same study, Kristen Nelson's study, use pulse oximetry. It's good, it's not 100%, because the first thing, if you had a gradual overdose where the patient just gradually becomes sleepier, end-tidal CO2 would be more sensitive, the tracing. You would see the respiratory trace decrease. They take fewer breaths. But especially if you deliver oxygen to the patient, they would still be well saturated. But not as many institutions at this point use this. There are pumps now that are in clinical testing that where you have your PCA pump, and there's a feedback mechanism. So you have a nasal cannula in with a little, and I don't have a picture. If I had known about this talk, I would have had a picture ready. Where you can monitor the respiratory trace. It is problematic because there's a feedback mechanism. So if there's no respiratory trace picked up from the nasal cannula, the IV PCA pump will shut off. If you have a child, for instance, the child goes, I don't like this cannula, and they rip it off and move it aside, and then they don't get any pain meds. It's an immediate. So we are working on this. One of my colleagues is actually working with the company to figure out how we can make it least bothersome to the child. Kids will tolerate a simple nasal cannula, but this is a little bit bigger. That is a problem. It would increase the safety of these devices, especially in those subpopulations, such as kids that have obstructive sleep apnea, but we are not quite there yet. Technically, they exist, but in the clinical practice, we are not quite good enough yet. Overall, opioid infusions in children, there's a little bit data. It's a British study published in 2009, and it's very interesting. So the British Health Service did this. So if you have a nationalized healthcare system, you can just sort of do these studies. They did pediatric opioid infusions, 10,000 patients who were collected data, and then they did epidurals, 10,000 patients, and then they compared. So you can go to the parent now and say they don't want an epidural for the surgery because they think it's too risky, but it's actually the same risk. So opioid infusions have There was a grade 1 incidence of cardiac arrest, 1 in 10,000, was a child with an underlying neurologic condition. And these are IV PCA or just continuous infusions, which in some institutions are used specifically in younger children. There were some respiratory depressions, and then there were other incidents like drug programming errors. These can be near misses, somebody picked this up, prescription errors, and so forth. Most of them were in one center. And the incidence of serious harm was very similar to epidural infusions and central blocks in the population, where also was 1 serious incident per 10,000. Okay, I'll move a little bit faster because I want to get improving analgesia. So opioids are just one tool that we use in children, and it's not the perfect tool. There are side effects. We are learning more about some of the adverse effects, how they affect immunity, how they affect hormones. It's not just respiratory, it's not just breathing. So we are trying to use multi-drug analgesic therapy. You're looking at increased efficacy via synergy, and you want to reduce the individual drug dosages. Or you would look, if you want to do almost single analgesic therapy, you really have to increase the efficacy and decrease the side effects. Combination of the two. So that's where we are going with multimodal analgesia. And there are various options, non-opioid analgesics. We talked about they are anticonvulsants. So this is your acetaminophen, ibuprofen, would be ketorolac, toradol, and so forth. NMDA receptor antagonists, we heard about tolerance. These receptors are involved in tolerance or prevention of tolerance, so they are very attractive in combination with opioids. And then final regional analgesia. I don't know that I think I want to get to my other talk, and I'll stop here with this part here. Any questions? I don't have too many studies because I just had to throw this together here. Yes?
I'm not sure what you mean by regional anesthesia. Will you use external application of drugs such as capsaicin on young children?
So capsaicin hurts. Okay? You can buy it over the counter, but that's a very low concentration. And the person who knows a lot about high concentration is sitting there, Dr. Raja, because he does this for some chronic pain adult patients. And so you can do an application. Do you block them, Raja?
Topically.
Yeah, topically block before, and then you put the capsaicin in. So they come into the clinic for a period of time. It's a high concentration.
Like young children?
Not in children yet.
What do you mean by regional? What are you referring to?
Regional analgesia is, epidurals, let's see. Yeah, this is regional analgesia, where you essentially, like epidurals, or you can do nerve blocks. So when you have pain in various locations, or you have surgery on a limb, on a leg, you can block along the spinal cord. There's the spinal cord. There is a space around it. Inside here is the spinal fluid, and then there is another space. The nerves go through. So with an epidural, you get right into this space. You can inject some local anesthetic, which will spread up and down, and that will block the nerves coming out. And then you have, yep, it's on here. And depending on how high you blocked, you know, if you put this for labor epidurals, it's put right here, and it will track to this area, and then the lower part of the body is numbed. You can also go and block an individual nerve supplying one of these areas.